Hello everyone, and welcome to Metacoccus video series, where we'll explore some high-yield USMLE Step 1 recall questions. Our goal is to break down these challenging topics, focusing on the key concepts that the NBME loves to test. Let's begin with this case. We have a 52-year-old man who presents for a routine health checkup. The patient is a former smoker with a 15-pack year history, but he quit smoking 10 years ago. Quitting smoking is the most effective measure to reduce his risk of lung cancer. He now expresses concern about his ongoing risk for lung cancer, especially given his history. Aside from his past smoking, the patient spends a significant amount of time in his basement studio restoring antique paintings, and he owns an African gray parrot. His cardiovascular and pulmonary exams are normal. While his history of smoking is the most critical risk factor for lung cancer, another environmental risk factor stands out in this case: radon gas exposure. Radon is a radioactive gas that is released from the decay of uranium, found in soil and groundwater. It can seep into homes through cracks in the foundation and tends to accumulate in lower levels of the home, such as basements, which is relevant in this patient's case, as he spends considerable time in his basement studio. Radon gas is inhaled and then decays, emitting alpha particles, which, although they have minimal penetration in human tissue, are highly mutagenic. These particles cause DNA damage in the respiratory epithelium, increasing the risk of lung cancer. Radon is the second leading cause of lung cancer in the United States, and for non-smokers, it is the leading environmental risk factor. However, the risk is compounded for individuals with a history of smoking, as is the case for this patient. The most effective way to address this risk is to test for radon in homes, particularly in areas like basements, and implement mitigation measures such as negative soil depressurization to reduce radon levels in home. Next, in this case, we have a 64-year-old man who presents with progressive dyspnea, a non-productive cough, and fatigue over the past several months. His history is notable for a 38-year smoking history, although he quit 4 years ago. On physical examination, decreased breath sounds and dullness to percussion at the right lung base suggest a pleural effusion, which is confirmed on chest CT. The scan also reveals diffuse nodular thickening of the pleura. A thoracentesis is performed, yielding bloody fluid, and a pleural biopsy reveals key histological findings: epithelioid-type cells joined by desmosomes containing abundant tonofilaments and very long microvilli. These findings are classic for malignant mesothelioma. Mesothelioma is a rare malignant neoplasm that originates from mesothelial cells, which line body cavities like the pleura. The primary risk factor for developing mesothelioma is asbestos exposure, which often occurs in industries like shipbuilding, insulation work, and construction. This patient's history of smoking does not directly contribute to mesothelioma risk, but can compound lung disease in those with asbestos exposure. Clinically, mesothelioma often presents with slowly progressive dyspnea, cough, and chest pain. Patients frequently develop pleural effusions, which can be hemorrhagic, as in this case. Imaging typically shows unilateral pleural thickening, and the lung parenchyma itself is usually unaffected. Microscopically, mesothelioma cells are characterized by numerous long, slender microvilli, abundant tonofilaments, and desmosomes. Immunohistochemical stains, such as calretinin and cytokeratin, can help confirm the diagnosis. Other diagnoses, like adenocarcinoma, small cell carcinoma, or squamous cell carcinoma, are less likely in this case due to their distinct histological features and typical involvement of the lung parenchyma, or central bronchi. Mesothelioma is unique in its pleural origin and its association with asbestos exposure. Next, in this case, a 64-year-old man presents after a motor vehicle collision, but his imaging reveals an incidental finding that is unrelated to the trauma: pleural plaques with calcifications, as seen on the chest CT scan. These plaques are focal or band-like thickening of the pleura, and they are characteristic of asbestos exposure. Asbestos fibers, once inhaled, cause chronic inflammation and lead to collagen deposition within the pleura. This process can take 20 to 30 years after exposure to manifest. The most common occupations linked to asbestos exposure include insulation manufacturing, shipbuilding, drywall work, and other industrial jobs where asbestos fibers are inhaled over time. Asbestos is particularly dangerous because of the long latent period between exposure and the development of conditions like asbestosis or pleural plaques. These plaques typically develop along the parietal pleura, particularly covering the ribs and diaphragm, as shown in this patient's scan. While the patient in this case doesn't show symptoms of asbestosis, which would typically involve progressive pulmonary fibrosis and affect the lung bases, his history of asbestos exposure remains a significant risk factor. Additionally, these plaques are often asymptomatic and discovered incidentally, but they do raise the concern for future complications, including mesothelioma, a malignant pleural tumor also associated with asbestos exposure. Let's quickly differentiate this condition from other occupational exposures. Beryllium, used in aerospace manufacturing, can cause berylliosis, which resembles sarcoidosis, but doesn't produce pleural plaques. Coal mining leads to coal workers' pneumoconiosis, which presents with small nodules in the upper lungs, while sandblasting is linked to silicosis, which also causes upper lobe nodules, but not pleural plaques. Thus, the patient's history points most strongly to insulation manufacturing, which commonly involves asbestos exposure. So, in summary, this patient's pleural plaques with calcifications are a hallmark of asbestos-related pleural disease, most likely related to his past occupational exposure in insulation manufacturing. Okay, guys, next case, a 76-year-old man undergoes an emergency laparotomy after a motor vehicle collision. Unfortunately, despite aggressive resuscitation efforts during surgery, the patient experiences cardiac arrest and dies. An autopsy reveals thickening inside the chest wall, specifically pleural plaques, focal areas of calcification that are highly characteristic of asbestos exposure. Further examination of the lungs shows fibrosis in the lower lobes, which is also consistent with asbestosis, a chronic condition caused by inhaling asbestos fibers. Asbestosis is a type of pneumoconiosis, a lung disease caused by inhaling dust particles, and it is most commonly seen in individuals with a history of occupational exposure. Professions such as insulation installation, shipbuilding, and pipe work are high risk for asbestos exposure. There is typically a 20 to 30 year latency period between asbestos exposure and the development of symptoms, which often include dyspnea, cough, and fatigue. On histopathologic examination, the most notable feature in patients with asbestosis is the presence of ferruginous bodies, which are golden brown fibers coated with iron protein complexes. These bodies are often rod or fusiform shaped and are visible under light microscopy. They form when asbestos fibers are inhaled and become coated with iron-containing protein complexes in the lungs. These ferruginous bodies are the hallmark of asbestosis and help differentiate asbestos exposure from other conditions that involve inhaled particles. The pleural plaques seen in this patient are common in asbestos-related pleural disease, and while they may be asymptomatic, they indicate past asbestos exposure and increase the risk for further complications, including mesothelioma and asbestos-related lung cancer. So, this case highlights asbestosis, characterized by pleural plaques and lower lobe fibrosis. The hallmark feature on histopathology is the presence of ferruginous bodies, which are specific to asbestos fiber inhalation and differentiate this condition from other pneumoconioses. Finally, a 76-year-old man presents with worsening shortness of breath, cough, and weight loss over several months. Despite being a lifelong non-smoker, his chest imaging shows irregular pleural thickening, raising significant concern for a pleural-based malignancy. The patient declines a surgical biopsy and opts for hospice care, passing away several weeks later. On autopsy, As shown in the image, his lungs are encased in a rind-like thickened pleural mass, which is highly suggestive of mesothelioma. Mesothelioma is a rare but serious malignant neoplasm that originates from the mesothelial cells lining body cavities, such as the pleura. It is most strongly associated with a history of asbestos exposure, which can take decades to manifest into disease. Common occupations linked to asbestos exposure include mining, shipbuilding, and insulation work. In this patient's case, although we don't have a direct mention of his occupational history, the findings are classic for asbestos-related disease. Histologically, mesothelioma can present in two forms: epithelioid, cuboidal or flattened cells, and sarcomatoid, spindle cells. In this patient, the likely histological finding would be spindle cells that stain positive for cytokeratins. Cytokeratins and calretinin are important immunohistochemical markers that help confirm the diagnosis of mesothelioma. Under electron microscopy, the cells also typically have long, slender microvilli and abundant tonofilaments, further distinguishing mesothelioma from other pleural-based conditions. Ultimately, mesothelioma presents with slowly progressive symptoms such as dyspnea, cough, and chest pain, much like what we observed in this patient. The imaging and gross findings of pleural thickening and encasement of the lung further support the diagnosis. Thank you for joining this episode of the 𝘕𝑚𝑒TOCOCUS video series. Stay tuned for more high-yield discussions on topics that frequently appear in your NBME and USMLE exams.